From the 35th meeting of the APA CRS in beautiful Singapore, I'm Josh Young. I'm here with Anurag Mishra. I'm excited to talk about something that I believe very strongly in, which is monofocal lenses. We're going to be talking about the Clareon monofocal lenses. So before I get to the questions that I really want to ask, let me have you sort of set the stage. How does the Clareon monofocal lens differentiate itself from other lenses?
I think that's a very pertinent question, Josh, that you've raised, because it's important for us to identify this and address this, because we have been very happy with the monofocals that we have had in the industry thus far. The Clareon came in with a fresh set of concepts. And it was, I wouldn't lie to you, it was initially a little difficult for us to accept that if we are very happy with the existing platform, where is the need to upgrade and go to another platform? But when we tried the IOL, we found out several facets of the IOL which were not existing before. So it was perfection and then polished to bear a different kind of texture. I must say that the experience has been overwhelmingly pleasant from the time that I've started using it to this, and the narrative derives its concepts from the fact that it's a new material which is much cleaner, much clearer, and it sits in the bag and looks at you just the way the surgeon wants the IOL to appear from inside the eye at the end of the surgery. We'll begin on that note when we try to expand as this goes on further.
So one of the topics that's always brought up at meetings are monofocal plus lenses. So how does this, what we're talking about here is a genuine monofocal lens. How does it compare to monofocal plus lenses?
Honestly, before the Clareon came in, I did not have much of confidence with the monofocal plus lenses, because I had never seen the monofocal plus lenses give a true functional intermediate vision. Most of the time I saw them working like a monofocal lens which gave excellent distance, but when it came to intermediate and near, they actually fell short of delivering. When the Clareon came in, it actually came in as an observation which I received from my patients. The patients came and told me, particularly after bilateral implantation, that they don't need glasses most of the time to read. Initially, I did not believe them because this did not promise to have anything other than monofocality. But when I went back and checked on the statements that they were giving, I found that the Clareon, particularly after bilateral implantation, was actually giving very good functional intermediate vision. To my surprise, I found that it was actually giving an N10 or an N8 at 50 centimeters comfortably with normal room light. They did not even need an extra light to read. So that was something that was a wow that came to me. Comparing a monofocal plus with Clareon, I would always go in with the Clareon because this does not have any added science to it from the optical perspective, but on the stage of deliverance, it definitely delivers.
Now, Anurag, the Clareon monofocal lenses are very obviously not the first monofocal lenses that you've ever used. How has the transition been to Clareon, and is there anything that you've had to adjust to work with the new material?
So as I said, the existing material, the existing platform that we had did satisfy all of us, all of the users across the world. But the Clareon actually brought in a fresh concept initially with its implantation science, because it was a gas delivered system, it had a canister, the assembly was different. So initially it was the implantation science that caught our attention. We never put focus on the material proper. The implantation was the only thing that was important. But as we moved on, we found that the IOL itself, without the assistance of the gas delivering it into the eye, was also superb to follow. It was, as I said, perfection added on a few facets or polished to have a new texture altogether. So the transition has been very good, and I was very happy when I heard that they're also launching it on the wagon wheel platform. So we don't have to have the in the previous assembly the gas delivered system. We can implant the IOL just like we have been implanting the Actisoft that was existent earlier. But the material advantage goes to the patient. So I'm very satisfied with the wagon wheel now. I was already happy with the autonomy, which was the dispensing system earlier on. So that's been the story thus far.
So I'm going to ask you the most important question from my standpoint as a cataract surgeon, which is, what is your selection process for a particular lens for a particular patient? When do you go to a monofocal lens?
Monofocal lenses are our go-to lenses. They are the ones who build up your practice. They are the one who advance your practice to the next level. The AT IOLs are wonderful. The torics and the EDOFs and the trifocals, they are wonderful platforms, but we all know that they are not required by all. So they are not universal IOLs. The monofocal IOLs are the universal IOLs. So when it comes to the selection, I would put in a Clareon monofocal in anybody and everybody who wants it, and everybody who gets prepared for it. The only thing to focus on out here is, during surgery, if you do not have an intact capsular bag in terms of the anterior capsule or the posterior capsule not being intact and integral, perhaps I would plan something different. But that also is not universally true. If you have a small section where the rexus is snapped, for example, or a small PCR in the periphery, you can still go ahead and choose the monofocal, the single piece monofocal that you had initially planned for the patient. So as far as selection criteria is concerned, there is nothing that prevents me from planning a monofocal IOL in any patient. If intraoperatively something happens wherein I feel that it is not safe to put a single piece IOL for that particular patient, I might just change my plan.
I have a question. I think it's a little bit challenging, may not even be fair, but it's not going to stop me. We're discussing a monofocal lens, and you're telling me that your experience with your patients is that they have some intermediate vision too.
Yes.
How do you think that that's happening?
So I also looked at it. I also tried to find out, because as per my understanding, the Clareon material and the Clareon design optically is not much different from where the Actisoft was. So I also tried to find it out. What I found was three things, of course unconfirmed, but these are three observations that I've made into it. Number one is, it leaves a bit of positive spherical aberration. The resultant positive spherical aberration of the eye is slightly on the positive side, and we all know that it imparts a depth of focus. So maybe that's reason number one. Reason number two is the broad landing zone. If you implant a 24 diopters IOL into the eye, it gives you the landing zone of 23.5 to 24.5. So the patient has the liberty to adjust the depth of focus. Number three is, it's a very soft material. So when it sits in the bag, particularly in patients who are not very old and who have got some amount of pseudophakic accommodation left, perhaps they use that pseudophakic accommodation and the optic shifts that slight wee bit to impart the intermediate vision to a functional extent. So these three are the things that I have thought of. But if you ask me to point out one of these, then I can't. But it is true that it is happening, and it's for all of us to see. Anybody who wants to try it out can do so, but I can assure you that it does give you, if not in all the patients, but at least in 90 to 95% of my patients, it does give a very functional intermediate vision. And in fact, you will be amazed to see that how many of your patients come back to you and tell you that they don't even need glasses to read if the readable material is kept slightly away from the face, say at around 45 centimeters. What is interesting, Josh, is after the switch that the world had from printable, readable material to the smartphones, from where we read most of our texts and contents, we have learned how to keep the smartphone a little away from the face. So everybody's working distance is shifted from 30 centimeters to 40 to 45. And that's where the Clareon works the best. So look at it for yourself and be amazed.
So those are really, really interesting thoughts. When I teach my residents, I tell them, you can tell an old ophthalmologist, because an old ophthalmologist will say, I'm comfortable with what I'm doing, I'm getting good outcomes, why should I change? So my question to you is, how does the Clareon material differentiate itself from Actisoft, which is already, very, very widely used, because I don't want to be an old ophthalmologist.
Yeah, that's a very interesting question. And in fact, I ask myself this question at least 1,000 times, if not more, before I actually started switching. There are two things that are from the technical perspective. One is the 360 degree square edge. So the Clareon has a square edge even at the optic haptic junction, which is not there with the Acrysof. Having said that, the Acrysof did a phenomenal job in preventing PCO years and years after its implantation. But I think Clareon is going to stretch that years and years by another 5 or 10 years, because with the 360 degree square edge and with the tachinus and fibronectin binding that was already existent with the Alcon material, it's only going to further or only going to defer the PCO formation in majority of the patients. The other thing that we have found out to our amusement is this functional intermediate vision thing, which we were discussing a moment back. So both of these things combined, the Clareon is a better material, technically speaking. From the surgeon's perspective, the moment you put it in, and when you see the patient under the slit lamp after 15 days, the Clareon would appear to you as one of the cleanest and the clearest materials that you have ever seen in your practice. I'll tell you something very interesting. The optical biometers that we have in the industry, when you ask the patient to sit before an optical biometer and you do not tell the machine that it's a phakic eye or a pseudophakic eye, the modern day optical biometers pick the IOL in the visual axis and they switch automatically their mode into the pseudophakic mode. That's what happens with normal optical biometers. When you ask a patient who has already got a Clareon implant to sit before an optical biometer, it does not pick that there is an IOL in the visual axis. It is so clear, it is so clean that it does not pick that there is an IOL sitting in the optical axis. It stays in the phakic mode and it does not go to the pseudophakic mode. So that's what changes the clarity in the optical medium, the glittering look of the IOL when you see the patient post-op. That's where it has changed the most for the surgeon. And of course, there are technical superiority indices that we just talked about moments back.
Very interesting. This is we live in a cool time when there are all of these new things going on, and this innovation in ophthalmology hasn't ended. There's no reason to expect that it's going to end now. You've made this all very, very clear. I'm excited to hear it. But most of all, I am grateful for the generosity of the time that you've spent with me today.
Thank you so much, Josh, for having me here. I enjoyed the time here and answering your questions. I really enjoyed and be honored to the opportunity you've given me. Thank you so much.